Well, I told her, he said, listen, he said he sent an email out to everybody with the schedule. I said, listen, I need to. Okay, so I asked him, I said, your schedule needs to be posted with everybody else's.
Camera.
So staff knows. Okay, then.
Darcy, can you hear us?
So. It's gotta be documented.
Yes.
Thank you. So when it's done recording, you want to see this on record. When it's done recording, keep recording.
Let me know if you have trouble hearing this. It's outside.
I think it's recording there, right? Yeah, especially getting microphone. It's from right there. It's okay. I'll just kind of-
It's like that.
It'll like, start downloading onto the, that one, and then I'll just send it. Okay.
Karen's doing one.
I'm gonna go to the restroom to see how many.
Hi, how are you?
Good, good, good. Oh, Steve.
Well, yeah.
Hello. Hi there.
And then they see the back of the room.
Brian. Me too.
You wanna try standing back there, see if it fits all the way?
Oh, no.
No, I'm just a shadow.
Yeah.
How's that?
Hello? Is that good? Can you hear me?
Yes, can hear you.
Clicker doesn't work though.
Because it blocks his view of it. Yeah, that would be better. Okay, nobody's eating. What's up with that?
Go ahead, go ahead. I'll go after you guys, yeah. No, go ahead, you. Okay, I will go first.
All right,
You know what? Let's turn.
have fun.
Oh, you can get through it.
Huh? I'm telling you, Colleen.
Oh, is this being recorded?
I know.
Awesome.
I mean, they're a handful.
Recording is on.
Right?
Yes.
Oh, yeah.
All right.
Okay.
Thank you guys.
Had to allow it
Thank
one
you.
time in my life. But I-
Let me see if there's anybody else in person, so we-
How about they-
Oh, yeah.
No, this is Robert.
Oh,
They have approach on
I thought I saw
salad.
it.
Yeah, you want to try that salad instead. Absolutely.
Absolutely, yeah. Is this something you think you're gonna try to start doing?
Yeah, I did it at my last job.
Yeah.
More work.
Oh. Oh.
It's a lot of.
Oh,
He does,
perfect.
I was having trouble finding things.
Yeah.
Your clicker is not gonna work on that.
It is, yeah.
So,
It is.
we're
It's
just-
just I can only go. It fails, but.
Yeah.
Oh, the arrow button.
No, just put on the PowerPoint.
Coming back.
Right on it. Try the other one, you want to try the one that's closer? Yay! Thank you.
Another rescue by Christina. How far back in the Sam?
Weird how it's close to that.
Do you want me to just sit closer and advance it for you?
I can get this part.
Yeah, just stand there then. They don't need. Or once you're done with advance, you can go back and come back.
That's how I know. I want that to work.
Okay, thank you.
All right, should I start? Can everybody on Zoom hear me?
Yes.
Yes.
Okay, so I'm gonna begin. I am Dr. Raab. I'm a psychiatrist. I work with Center for Progress and Excellence, and a lot of them are here today, actually, in support. I also work with the team out in Lehigh with Elite DNA. And today we're going to talk about the psychiatry of post-traumatic stress disorder. I have a lot of slides and so much time to get through it, so I'm going to ask that we hold the questions for the end. If you have any questions, my email is there too, as well. So this is some of my experience with post-traumatic stress disorder. So I worked at the VA for about 2.5 years, and I did a lot of training there as well. I worked in corrections, and there's a program called the Home Base Program, and they see veterans for no cost. And this is something that they do here. So I was a part of that program. And then I currently work with Center for Progress at the Global Crisis and Empowerment Center. So this is kind of the layout of my lecture. We're going to start with defining post-traumatic stress disorder. Then we're going to go into comorbidities, some clinical approaches. And these approaches are not from like the therapy side of things, but more of like if you were a psychiatrist or maybe a case manager, what are some things that you can do?
Did you see Mary trying to come through?
Oh, no, somebody.
Yeah, because she sent me a screenshot saying she was waiting to be admitted.
I can leave right here.
And you guys are hearing me okay on Zoom?
Yes.
Okay.
I don't see anything we need.
We'll do chat.
Is this being recorded for future views since we're getting a late start?
It is being recorded. Yeah, I'm probably gonna go over 1 o'clock a little bit.
Yeah. Thank you.
Okay, so first, I want to talk a little bit about some of the pathophysiology of post-traumatic stress disorder. If you remember, the limbic system is a really important part of what we do. The hippocampus, in particular, is this part of the brain that kind of stores memory. And it's also responsible for the processing of memory. And in post-traumatic stress disorder, we can actually see that it's smaller in size if you do an MRI. And we think that's because there's so much bombardment of that hippocampus in PTSD. You also have the hypothalamus, which affects your cortisol, which is your stress hormone. And then your amygdala is responsible for your fight or flight system. So what happens in post-traumatic stress disorder is this limbic system gets real reactive and it overwhelms the frontal lobe. So that's why when there's a loud noise or something like that happens, all of a sudden it might lose control because that frontal lobe gets overwhelmed. So to kind of give an example of this in action. So if you think about like a soldier who was on patrol, they are taught if anything gets in front of that car, it's on. It's not a good situation. You take that same person, now they're back in the States and maybe they're getting cut off in traffic. Well, that hippocampus has that, it's part responsible for that stored memory. And it's right there, part of that emotional center. And so what happens is this is all flashing, the frontal lobe gets overwhelmed, and you wouldn't want to be the person who cut off the person in traffic. That's kind of an example of it in action. I'll just get real close. Now, if we were to take a really strong magnifying glass to that limbic system, really strong, what you would see is the neurons. And how they communicate are what's called these neurotransmitters. And some of the big ones at play are serotonin, norepinephrine, dopamine, GABA. And this is what we're kind of targeting in our psychopharm. We're essentially trying to stabilize what's been disrupted. We're going to talk about that. And so now let's talk about the DSM criteria. So first you have to have exposure to trauma. It's either direct or by witness, and it has to be really significant trauma. It has to be pretty much life-threatening or close to life-threatening. Criteria B is you have to have a re-experiencing of that trauma. And that could be by nightmares, flashbacks, or even just that emotional response that you feel when you get triggered. I kind of highlight nightmares here because as a psychiatrist, it's something that we look at and we treat. And I've treated a lot of patients with PTSD over the years. Nightmares are a really big deal. If you think about a patient who has a PTSD nightmare, they wake up and they're already on edge, their adrenaline is flowing, that's only going to set them up for a really not so good day. So the nightmares are something that you really need to treat. And then criteria C is avoidance of trauma stimuli. So for example, Walmart is kind of, I don't know if you guys have heard this, but people don't like going to Walmart. If you think about it, you have loud noises, you have crowds, people are up in your space, there's all sorts of potential triggers. And then this, I actually got this picture from Vietnam. And if you look at it, it looks like it could easily be Fort Myers. And so a lot of times I had patients that would, avoid, they wouldn't canoe, they wouldn't kayak, because they're trying to avoid that trauma. And of course, fireworks. Kind of ironic that, for example, our veterans, July 4th is actually a pretty rough holiday. Great. Criteria D is you have negative alterations in your cognitions and mood. So if you think about what we talked about, that emotional part of the brain is overwhelming the thinking part of the brain. And that sets us up for all sorts of cognitive distortions, feeling isolated, we might have some negative affect. So this is one of the things that is a target therapy. Of course, we have to have 2 of these arousal type symptoms, such as hypervigilance, a heightened startle reaction. And then just to point out, you have to have the symptoms for more than 1 month. If it's within a month, that would qualify as acute stress disorder. The criteria are pretty much similar, it's just within that first month, it's acute stress disorder. After a month, it could become post-traumatic stress. And then I just highlight the risk of suicide. It's really significant in this population. At the VA or in the military, there's more people dying by suicide than there are by combat. That's how significant it is. And then if it's ages 6 and younger, the criteria is a little bit different. It's pretty similar, it's actually a little bit easier to diagnose. They thought they might have been missing some of those diagnoses, so they added a subsection in the new DSM. So let's talk about some comorbidities. So of course you have depression, anxiety, nightmares we talked about, REM sleep disorder. So what happens in REM sleep disorder is the patients are moving around in their sleep, they're kicking, they're punching, all sorts of stuff. And what we think is in REM sleep, when your eyes are going back and forth, that has something to do with the processing of the trauma. And so that gets disrupted, and we see a lot of REM sleep disorder, in PTSD. Also, you see a lot of alcohol use in PTSD, and that can cause REM sleep disorder as well. And then OCD. If you think about it, if somebody feels like they're losing control, like they have a lack of control, one of the ways in their psyche they might try to gain control is with these compulsions. And so one of the big ones that you'll see is checking doors. If you think about it, checking doors fulfills a compulsion. It also fulfills the hypervigilance because they're on the lookout. So the most common thing I see with patients is, I'll ask them, like, how many times do you check the doors? And they'll say like 10 times. That's the hardest part. Of course, traumatic brain injury, panic disorder, and then substance abuse. And one of the reasons you see a lot of substance use is because of the avoidance that we see in PTSD. So in PTSD, people are trying to avoid any sort of, that feeling, that flashback. They're trying to stay away from it. And sometimes they'll do it by self-medicating. So big ones are alcohol and marijuana. And what's interesting in marijuana, I see a lot of it, is we know marijuana causes paranoia, and we know PTSD causes people to already look over their shoulder a little bit. So a lot of times you get this hypervigilance, paranoia kind of combination, which can be pretty severe. And then I have borderline personality disorder. If you think about what we were talking about with our limbic system, how it's real reactive, it makes sense that this could lead to a disorder that causes emotional dysregulation. So a lot of times we will see the development of borderline personality disorder. I actually had a patient, it was interesting, like 2 weeks ago, and there were 2 siblings, and they both went through trauma, and they expressed it in different ways. So one patient was actually diagnosed with borderline personality disorder, there was cutting and all these things. The other patient didn't say anything. They were depressed, they were very quiet, they thought everything was okay, and then there was a suicide attempt that occurred. So trauma can affect people very differently. In some cases, it can lead to borderline personality disorder. Okay, so now some clinical approaches, and this just isn't for the psychiatrist, this would be for anybody who's maybe not the therapist, is kind of what I'm going for. So this is some stuff that I've kind of learned just from, I've worked a lot with PTSD. So first is building rapport. I would say building rapport is maybe more important in PTSD than a lot of other things that I treat. It's important to be non-judgmental. You want it to feel like a safe space. The trauma is often not shared with others, even their family. So they won't even talk to their, family about this really distressing, part of their life. And yet here they are, they're coming to you, this stranger, to talk about it. And then discussing trauma and meeting the patient where they're at. So you may not want to discuss it right away, when you first see that patient, they may say, I don't want to talk about it, like, I don't want to go there. So at that point, you might want to focus on the symptoms. So I might jump into, okay, let's talk about flashbacks, nightmares, these sort of things. They might not show, they might worry that you're going to talk about it. Sometimes I'll even reach out to the patient, but everything's okay, you know, I hope to see you next week. And then in later visits, patients might come out with the trauma. So you just ask them a question, and the next thing you know, they go into it. And I'm going to go into a little bit of how I approach that on the next slide. Okay, so the topic of therapy. So this is coming at it from, you know, not the therapist, but you're another provider. So I see part of my job is getting that patient ready and appropriate for therapy. I see that as part of my job. And so there's some different ways that I do it. So psychoeducation is important. So you want to be aware of the different types of therapy, educate the patient, and you really want to emphasize to the patient how important a part of their recovery is. Medications will do so much. They will help, but they will not get them to a state of full recovery. So in terms of motivation, I might use, it depends on your patient, right? You treat the patient that you have. So in the military, I might use an analogy such as combat. You can do this. You went to combat, you went to war, this is going to war, this is going to battle. I might look at something that a patient is resilient in, so say they're a successful business person, I might make a point of their resilience there and, you know, emphasize, you know, look at what you've done in business or family life. I know you are a strong person, you've demonstrated that. This is something you can do. And then psychiatric treatment. So that's the SSRI is really the big one. And so what we're trying to do with that SSRI is essentially to be able to kind of turn the volume down a little bit, help the patient be able to let go, and really to be able to engage in therapy. You might hear a patient tell you that they're worried that therapy will make the symptoms worse. I don't want to go to therapy. I just want to see you. And that's part of that avoidance, you know, that I was talking about, right? That they want to avoid that. And so sometimes I'll kind of draw like a little graph like this. You know, maybe they saw a therapist once, and I'll say, you know, yes, it can keep the symptoms up a little bit. That is a possibility. But over time, as you engage in that therapy, those symptoms will decrease. And then we talked about the patient discusses the trauma in an appointment. So you're in your, and this happens, I'd say if you treat a patient long enough, this will happen. It might be the 7th visit, it might be the 5th visit. You know, you ask them, how's your sleep? The next thing you know. And you have 20 minutes, right? And you're like, oh my gosh. You're gonna be behind in your schedule. So accept that. But I actually see this as an opportunity, like a golden opportunity. So the patient is going to talk about it, you know, in front of you. And I make a point of saying, look at what you just did. You talked about your trauma. You did it. You haven't done it in, you know, 10, 15 years. You don't talk about it with your family. You just did it. You just prove that you can do it. Unfortunately, I only have, you know, 15, 20 minutes, and I see you every month or so, and I don't have those tools, but we have great therapies for this. And you just, the hardest part, you just talked about your trauma, and you've been doing the treatment, we started on SSRIs, you're at that point where I think you're ready to do the therapy. So that's kind of how I approach that after, you know, getting behind. So I've had patients tell me this, you know, why should I listen to you? You've not been through this. My daughter tells me this sometimes, not about this kind of trauma, but so the patients may tell you, you know, why should I listen to you? You know, you haven't been through this. And I tell them, but my approach is that you're right. I have not been through this. I have not been through combat. I have not been abused. That is correct. However, I have experience in treating trauma, and you're going to know that I care. And so that's kind of how I approach that. All right, so now let's talk a little bit about therapy. So what's actually done in individual therapy? What are they doing? What are their goals? Okay. So one of the goals is they're decreasing limbic reactivity, right? We kind of talked about that. And then another one is processing the trauma. There's something called stuck points. I don't know if you've ever heard of this. There's a theme there. Guilt is technically not a stuck point, but it kind of is a theme there. So if you think about it, like when you're talking to the patient, they might say they feel guilty. You know, I should have saved everybody. You know, the abuse was my fault. You'll hear these kind of things. And you might be sitting there as the provider and say, you're not at fault. And the patient might even be able to verbalize that. Yeah, this doesn't make sense. I am not at fault. However, in their brain, there is a stuck point there. There's an emotional attachment to that trauma that is stuck. And so in therapy, that's one of the things that they're trying to get at, is to essentially unstuck and stick that stuck point. And they do a lot of coping skills. Reducing avoidance is a big part of therapy. So, you know, they don't want to have anything to do with that trauma or that feeling or anything like that. And so what therapy does is it exposes them to that and it goes down. So they don't feel so much of that stimulation. And then how does the trauma affect essentially that frontal lobe? So how is this affecting your day-to-day thoughts? That car's jumping in front of you, and you have all of these thoughts. How is that affecting you? And that's CBT, that's cognitive therapy. So I'm gonna talk about, there's 4 types of therapy that you should know about. And some of them are done here. Trauma-focused cognitive behavioral therapy. This is kind of a little quick synopsis of it. And so it's divided up into these phases. They have a coping skills phase, they go through the trauma, and then they kind of apply everything. This is done with kids, specifically trauma-focused CBT. Here in the program here, they do it, I think, for 3 to 18-year-olds. It's extremely effective. And then cognitive processing therapy is also CBT, but this is what's done in adults. And this is a big, when I worked at the VA, this was a popular mode of treatment. And this is essentially what we were kind of talking about. There's 2 others you should know about. You probably heard these terms. So EMDR is eye movement desensitization and reprocessing therapy. And so what they're trying to do is get their eyes moving when they're doing the processing. The theory is remember we were talking about REM sleep and how the movement of the eyes might be responsible for processing of trauma. So the theory is that you're kind of enacting that system while you're going through the treatment. And there's good evidence, so it's very effective treatment. And then this last one here, prolonged exposure therapy. This is really big on exposure. It's really difficult. So patients will tape themselves, they will have homework about the trauma. It's a lot of trauma. One of the key things is knocking down that avoidance in prolonged exposure. It can be the hardest one to get through for the patient as well as the therapist. Okay, so now I'm a psychiatrist. We're going to talk about psychiatric medications. We kind of talked about those neurotransmitters. And so essentially what we're trying to do is stabilize that system. The effect is we're trying to lower the volume. We're trying to help patients let go, get control, and be able to get into therapy. So there's actually only 2 FDA-approved treatments for post-traumatic stress disorder. Yeah, we have how many medicines? There's only 2. Does anybody know what those?
Paxil and Zoloft?
Paxil and Zoloft, very good, very astute. Nicholas provided it. Nicholas has been working with me. He's doing a good job. All right. So yes, there are 2. There are only 2 FDA approved. So why would you choose one or the other? I'm not gonna get into too much about some of the differences of Paxil and Zoloft. What I will say is we tend to avoid Paxil a lot of times, because we know Paxil has a lot of drug interactions, it's anticholinergic. So a lot of times it kind of is one of those that's in the back of our mind. However, in post-traumatic stress disorder, it's one of my go-to medications, especially if you have a patient who has a lot of hyperarousal, hypervigilance. Paxil is a less activating SSRI. So it is a good option. And then you have Zoloft as well. So these are the only two FDA approved medications. So I dug into the VA's guidelines. They have a very good official guideline on their recommendations for PTSD. And they actually recommend 4 medicines, and 3 of them are SSRIs and effexin, venlafaxine is an SNRI. They make a note, they know that those are not FDA approved, but they have good evidence to support that. And I do go to those. They're not FDA approved. However, you are on pretty good standing if you want to go ahead and use one of those, especially if they fail the others. This is from the VA guidelines as well. The VA spends a lot of money on research in PTSD. It's a great resource. I really want you to pay attention to this like top line here that shows moderate evidence, because everything below that is really, there's not much there. So they say they recommend those 4 medicines, and then Prazosin, they say it's not for PTSD, but you can use it for nightmares. They kind of say behind that it says it's not recommended or not recommended. They kind of leave it kind of up to you. And then for augmentation, nothing, essentially from the VA guidelines. And then there's Prazosin again, yes. It says, you know, they're not going to say either way for Prazosin. However, we see tough cases, especially in the roles that I've been in at home base and at the VA. So what do we do? So I want to just kind of make you aware, these are used sometimes in PTSD. So antipsychotics, they are off-label. There is studies that are mixed, to be generous. There's some that say it's in support, and some that say it's not so helpful. Of the 3, I'd say quetiapine maybe has the best evidence. And what these are used for is those patients who have failed a lot of medications, they failed therapy, they've been through a lot, and they're really good for the hypervigilance, hyperarousal type of symptoms. It kind of makes sense to us as psychiatrists that therapy might be helpful in this way. And then mood stabilizers, so divalproex and Depakote. This is used in that way as well. However, I would put that behind the Seroquel in terms of your treatment options. You really want to focus on the SSRIs. And then nightmares. So the reason I have 2 beds in this picture is if you ever ask a patient or you ask their spouse, a lot of times they're not sleeping in the same room because the nightmares are really bad, and they're kicking and they're punching, maybe they have a sleep disorder. So Prazosin is kind of our go-to. Yes, it is off-label, the results are mixed, but it's a community-accepted treatment. You're on good standing to go ahead and use it. What it does is it calms your fight or flight response while you're sleeping. It's an alpha-1 antagonist. One thing I've learned is, I don't know if this happens in Athena here, but everywhere else I've worked, it defaults to putting in that this is a treatment for the prostate. And so then I have patients come back to me and they're like, you know, what are you doing to my prostate? You know, you're supposed to be my psychiatrist, and then you have to go explain that. And so I don't think it comes up in Athena, but I've had that experience many times. Trazodone is a treatment for nightmares as well. We often forget it is an alpha-1 antagonist as well. So that does help with nightmares. And then cyproheptadine, which is very active. That's again for this. That would be like my 4th or 5th line treatment. And then sleep hygiene and CBTI, do not forget about that. Those are actually first line treatments. You want to ask them questions about their sleep, What's their routine? Are they having trouble falling asleep, staying asleep? What's going on? What's your room look like? You want to make sure you ask all that. All right, so benzodiazepines. So I have 2 little kids. I don't know if anybody has seen the movie Encanto. So we don't talk about Bruno, it's this big song there. So a lot of times we don't talk about benzo, but we need to. I've been to a lot of lectures like on anxiety and they just skip it. I'm like, well, let's talk about it, we're gonna discuss them. And then I know like Dr. Ricci and a lot of people are making a policy actually for Elite DNA in terms of our use of benzodiazepines. There's something additional to say about post-traumatic stress disorder. The research is very clear. It is bad in PTSD. And if you think about it, we talked about like the SSRIs are to kind of turn the volume down, to be able to help the patient cope. Well, what benzos do is they just knock it out. It's a tranquilizer. And so if in therapy, our goal is to reduce the avoidance, and they have a pill that can just knock out that, that feeling, that sensation, you're actually enabling them in some sense. And so long-term, and there's really good studies showing long-term use of benzodiazepines in PTSD worsens PTSD symptoms. We know about all the other stuff, respiratory depression, addiction, all that kind of stuff. But in PTSD, it is actually hurting their recovery. The patient will tell you, this helps me. I hear what you're saying, but it helps me. It helps calm me down. And so what I will say to the patient is, I hear you. I don't argue with you. I know it does help calm you down in the moment. However, in the big picture, we're not doing so good. I may not stop it today. I may just lower it today. There's a lot of things we can do, but know that long term, this is hurting your recovery. And I may explain what I just kind of explained to you. Okay, for pediatrics, so there are no FDA approved pediatric medications for PTSD. There's some evidence. I was reading about SSRIs, Topamax, Prazosin. I've never used those. SSRIs, keep in mind, if you have a pediatric patient and you think there's PTSD, keep in mind those meds we talked about that we know work in adults. So your Prozac and Zoloft may also be beneficial for PTSD if you think that that's part of the patient's picture, because we know that there's FDA approvals for other things. So the VA has a big budget, so we know a lot more in adults than kids. If you want to know more about this, there's a great up-to-date article on pharmacotherapy in PTSD in children and adolescents. And I could email that as well if anybody's interested in that. Okay. And so some other things that are being done, there's something called alpha stim. I do this a lot. This is a little handheld device. It operates on this process called cranial electrotherapy. It provides a little electrical impulse, and you can use it as needed. You can use it every day. This is employed a lot at the VA and also in the military. I had a lot of success too with patients who are on benzodiazepines, trying to get them off of it. So this is kind of a neat device that's used. Propranolol is an interesting topic. In the military right now, if somebody goes through combat, there's studies showing within hours, if you give them propranolol, if you knock down that adrenaline response right after the trauma, the thought is that trauma and that adrenaline response are being connected right there and then. So if you can disconnect that right at the time of the trauma, you may prevent the development of PTSD. So this is something that is actually being used. Some really interesting studies. And then virtual reality. So I got Jason trying it out. So they do virtual reality at the VA. It's very effective, actually. Just like prolonged exposure, it's very effective. However, it's really hard to get through it. That makes sense. You might be playing pickleball. All right. And some Southwest Florida resources. So these are some things that are in our area here. There's something called ACT, which is Abuse Counseling and Treatment Center. It's good to have that number handy. They have a 24-hour hotline. They have a shelter. And they also can do some immediate therapy as well if somebody is abused. Here at Elite DNA, we have the Shift Therapy program, which does individual and group therapy. And Chantel was nice enough to give me a bunch of information. She also sent out an email, I think yesterday, in terms of the referral process. What I will say about this is, it's important when you refer that the patient is ready and they're appropriate. And I'd say most of the time that's not the case necessarily the first time you see that patient. If you put in all of that really good hard work and get the patient to the point where they are ready to engage in therapy, it's really great that we have that here as part of Elite DNA. So Chantel and others are doing really good work in that area. There's 2 residential programs. They're actually dual diagnosis programs. There's the Willow in Naples. I reached out to Acadia to see if they had anything. They gave me information about this place called the Wellness Resource Center. And they have some pretty good treatment program. They also accept like all major insurances and stuff. So if a patient needs a little bit higher level of care, that would be potentially a place to go. And then if the patient is a veteran, the Veterans Crisis Line, there's the Bay Pines VA and all their branch campuses. There's that home-based program I was talking about. They will see veterans. They will also see veterans who had an other than honorable discharge. They will also see family members of veterans. And maybe if there's a problem with them getting connected at the VA, this is a great place where they can get psychiatry and therapy and treatment. They also have a free program where they send them up to Boston for 2 weeks and they do intensive therapy, and it's all paid for. And then local AMVETs and vet centers. So these are kind of local places if you have a patient, like you can Google what's in their area. And just, yeah, this is pretty much my last slide. So there's something called vicarious trauma, if you haven't heard of it. It's when you as the provider start to have some of those symptoms, some of those PTSD symptoms. It is very real, especially if you're doing a lot of this type of work. Coworkers are a really good source of support. Sometimes after a really tough case, what I'll do is I might go into my coworker's office. I just had a tough case. Can we talk about ice cream or whatever? Coworkers are really important. And then I put the EAP number here. This is for Elite DNA. If you have a medical plan with Elite, this is available at no cost. And this would certainly be a place where this would be appropriate to use EAP. That's a problem. And that's all I got. I don't know what time it is.
We're doing great.
Oh, okay. I have some resources at the end, but yeah, if anybody has any questions, I'm also happy to talk about this stuff if somebody wants to email me. My email is eric.r@elite-therapy. Yeah, I'd be happy to help or in any way. Thank you. Does anybody online have any questions? Oh, I bet you're on. Probably ready to their next patient.
Thank you so much.
Thank you, Dr. Rob. That's great.
All right, thank you. Thanks for coming. It's a great one, man.
On the front.
Welcome.